Normal memory problems as you get older are that sort of, you know, the senior moment, the tip of the tongue phenomena where you meet somebody you've known for years and all of a sudden you can't think of their name. Or you're talking about a movie star and you can't think of their name, but it comes back to you later. Or you walk into a room and you say, what the heck did I come in here for? But it happens from time to time. That's normal. The important thing is it only happens from time to time. When it starts happening all the time, that's when you got to think that maybe there's a problem.
Dr. Susan Vaitekunas is co-director of the Anna and Louis Goldfarb Jewish General Hospital in Montreal, Canada. She was recently in Barbados as a guest of the Barbados Alzheimer's Association to deliver a public lecture on dementia. Dementia is a degenerative brain disease or syndrome which affects a person's ability to carry out daily functions.
It involves a decline in memory, starting with recent memory, and later affects more remote memories and will affect other brain functions. And one way of thinking of dementia is, think of an onion. When you plant an onion, you plant a seed. And as that seed sprouts, it starts to get bigger. And as the onion develops, it develops more and more layers. And as we grow up, we develop more memories and more skills and more experience. We develop more layers on our onion. But as a person develops Alzheimer's disease, think of it as those layers start to fall off and fade away till eventually you get back to that core again. The most important cause is Alzheimer's disease. It involves approximately 50 to 70% of dementia cases are due to Alzheimer's. And if we look at the brains of Alzheimer's patients, they have what we call amyloid plaques. Amyloid plaques are collections of protein. These plaques come from the breakdown of a much larger protein that's called amyloid precursor protein. And in some cases of Alzheimer's, a small amount, approximately 5 to 10%, and these are the cases that happen at very early ages. People have mutations in things that break down that large protein, which causes the amyloid to accumulate. In other people who develop the disease later in life, we're not quite sure what is the mechanism that causes these amyloid to accumulate in the brain. We also see other proteins called neurofibrillary tangles, and these ones occur in the cells themselves and may lead to the cells dying. With this accumulation of abnormal products, the brain shrinks, becomes smaller. About 30% of people with Alzheimer's actually also have what we call mixed dementia. So they not only have the changes of Alzheimer's disease, the plaques and the tangles, but they also show signs of strokes. And we call this mixed dementia because they have both vascular and Alzheimer's dementia. So here we have a normal brain with the white matter, the gray matter, and this is the part of the brain that's important for language, and here we have the part of the brain where we make our memories. Contrast, we have a brain of somebody with Alzheimer's disease, and you can see, it's plain to the eye that the brain is shrunken. It's much smaller. There are bigger spaces around the brain. And if you look at the area where memory is, it's almost gone. So as people develop Alzheimer's, their ability to make new memories goes away. It's like 5 minutes ago never happened. They can't remember, and it's not their fault. Their brain is incapable of remembering. It also affects other areas. As you can see here, the area for language is very shrunken as well. So if you were to talk to a person with this brain in real life, They might have difficulty understanding what you were saying to them, and they might have difficulty telling you what various objects were, who people are. Their sentences might be very simple. They might be fragmented. The next most important type of dementia is vascular dementia, and this is dementia that is caused by problems with circulation to the brain. And it's probably going to become a more important cause over time, because with people adopting what we call a North American diet and eating a lot of junk food, a lot more people are developing problems like high blood pressure and diabetes and high cholesterol. And so I think in the future this type of dementia is going to become much more common. It can result from repeated strokes, or even sometimes one stroke if it happens to be in a very important part of the brain. It can also result from just having poor circulation to the brain. If you have a blockage in the arteries that supply the brain so that not much blood flow is getting up there, that may cause areas of the brain to start shrinking. These patients can show a stepwise deterioration. That means they're stable for a while, they get worse with a stroke. They're stable for a while, they get worse with a stroke. But they may deteriorate gradually as well. The other important point is if you've had a stroke, and that might be a very tiny stroke, what we call a silent stroke, it greatly increases your chance of showing symptoms if you have those plaques and tangles in your brain, if you're prone to develop Alzheimer's. So if you have a history in your family of Alzheimer's disease, it's very important to take good care of your health. Another important dementia, and we've only really realized this disease in probably the last 20 years, is something called Lewy body dementia. And it probably accounts for 1 dementia in 5. These abnormal cells are also found in people with Parkinson's disease. But in Parkinson's disease, they're only in the part of the brain that's important for movement. And that's why people with Parkinson's disease don't move very well. They become very stiff. They have trouble walking. But in Lewy body dementia, we find these cells all over the brain. Now, the reason we didn't know this disease existed in the past is because it's similar, but a little different from Alzheimer's disease. The patients can show evidence of Parkinsonism, which is similar to Parkinson's disease. So they become stiff, they slow down, their balance is poor, they have a lot of falls. They also are prone to have a lot of visual hallucinations, seeing things that aren't there. They may have fluctuating alertness, so you may have somebody who falls asleep and you just can't wake them up, and later they're perfectly normal. Or there are periods where they're more confused than others. They can develop what's called a REM sleep disorder. Now, REM stands for rapid alternating movements, and this is this is the period of sleep where we dream. And normally, when we dream, our brain is very smart. It paralyzes our muscles. So we can't really act out on our dreams. We may dream that somebody is chasing us, but we're not running in our bed. But in REM sleep disorder, people aren't paralyzed, which can be a problem for the person who shares the bed with them. And I've seen movies of people taken in sleep labs with this, and it's very scary because they often have dreams where they're fighting with people. And they're sleeping, but they're fighting. And these people are also very sensitive to antipsychotic medication. These are medications that were developed for use in schizophrenia, But they're also used in people with dementia because we don't have anything better when, for example, they become aggressive or they have hallucinations. And because these people with this disease are prone to hallucinations, they're the ones that doctors might put on medications. So it's important as a doctor to recognize that people might have this disease because it can affect our choice of medications to treat hallucinations. In the real world, we don't use scans. We actually sit down and we speak to the patient and we speak to the person who comes with them, because we always, whenever we see somebody for memory complaints, we always ask that they bring a family member or a close friend with them, because one of the problems when seeing patients with dementia is they don't always remember that they don't remember. And they don't remember all the problems that they're having. So you need to talk to somebody else besides them. So the history is very important, and it probably takes up a large part of the evaluation, is getting a story of, you know, what are the problems now, and then going back over time, when do you think it started, and because we'll ask probing questions, you know, as to, because we want to get a picture of how the disease evolved and what was the first symptoms, because that will help me as a doctor know exactly what kind of disease do they have. In taking the history too, we want to ask them about their functioning. Are they having difficulty with their day-to-day activities, things like banking, etc.? We want to know if anything dangerous is happening in their lives. Have they gotten lost? Do they try and wander out of the house? Are they driving a car? Have they had any accidents? Have they left pots on the stove to burn? That kind of thing. Next, as a doctor, I want to review their medications and their medical conditions. First of all, there's a lot of medications out on the market that can have negative effects on brain function, especially perhaps not in a young person, but in an older person who is starting to develop memory and thinking problems. They may not react to medications the same way. So we want to review their medications and make sure they're not on something that might be making them more confused. It's important to know their medical conditions because, for example, if somebody had a history of breast cancer, this is a cancer which can possibly spread to the brain and might present the same as memory complaints. So it's important to know about that. And you know, maybe they have diabetes, and I want to check that their diabetes control is good, because that could affect their memory and thinking as well. As well, we want to evaluate them for conditions like depression and delirium. Depression is a mood disorder, but it also affects people's ability to pay attention to things and concentrate. So when people are depressed, they often have trouble with their memory and thinking because things aren't going in to begin with. And depression and dementia may coexist in the same person. So as a doctor, if they're depressed, that's something that I want to take into consideration. And I want to treat their depression first, because if I can make the depression better, their thinking and memory problems, while they may not go away, they may not be as bad as they initially seemed. I want to evaluate patients for delirium as well. Delirium is a more acute medical condition that's characterized by problems with attention and concentration, and it fluctuates. And it's probably, I call it the last real black hole of medicine because it's a very important condition in the elderly. But as doctors, we don't understand what's going on in the brain of delirious people. But they become acutely confused. And so this would be, as opposed to dementia, which develops over months to years, and you can't usually put your finger and say it started on this day at this time. In cases of people who are delirious, they may appear similar to demented people, but it comes on quite suddenly. They're fine one day, they're not fine the next. And it's important to think about because it's one of the ways the elderly tell us that they're sick. Another thing we'll do is we do a physical exam because we want to make sure that there isn't an undiagnosed disease in people. And in the physical exam, as a doctor, we're going to concentrate on examining the nervous system because we want to look especially for signs of stroke or weakness on one side or changes in the reflexes that might indicate that there's something different going on in the brain. Because the point here is in Alzheimer's disease, the nervous system exam is basically normal, especially in early stages. The next thing we're going to do are tests of memory and thinking to actually see how bad, like what areas of thinking are involved. Some simple blood tests looking for other medical conditions, things like thyroid problems, diabetes, high calcium, kidney disease, anemia, vitamin deficiencies, things like that. And as the last thing we do is brain imaging. But to be honest with you, brain imaging is often not very helpful in this disease. As I said, the main thing is the history and the evaluation in the office. It's the evaluation of dementia, I always think of it, it's really low tech. It really comes down to, you know, my skills as a doctor without any special equipment. If you look at normal aging and dementia, there's sort of, you can't put that line exactly where one condition ends and another one starts. So we've defined this condition of mild cognitive impairment, which has really become a hot topic of research because we think if we're going to get to the bottom of these diseases and treat these diseases, that this is probably the stage where we're going to have to start treating people in the future if we ever come up with a treatment. So in mild cognitive impairment, generally both the patient and their caregiver or the person who comes with them, because I would say at this point they don't really need a caregiver, both of them report that there's memory loss. And when we test them, we agree, yeah, your memory's not as good as we would expect for your age. But they're still able to do everything they've been doing. There's no drop in their function. If they're working, they're still able to work. They might have to make more notes, you know, they might have to use an agenda, but there's no definite functional decline. They may have mild decline in other areas of thinking on the MOCA test, but not bad. And when we follow these people over time, about 10 to 15% of them per year will get worse to the point where we'll say that they have a dementia. But, and that's a big but, there's a group of them, depending on who studies them, of about 10% to a quarter who never progress. Even if you follow them for 15 years, they don't get worse, and some of them get better. So when I'm faced with somebody with this condition in the office, all I can say is we have to follow you closely. So in mild dementia, as opposed to mild cognitive impairment, people start to have problems with function. So they may pay the same bill, start paying bills twice, or pay a bill when the statement actually says they have a credit, or they start having problems remembering to take their pills, or they may have trouble remembering where they parked the car. And as things go on, it gets worse. They have trouble remembering what day it is. And also, as people start to dement, and remember when I said in mild cognitive impairment, both the patient and the person who comes with them say they have problems with their memory. Typically, once people get to the point where they suffer from dementia, the person with the disease often will say, I don't have a problem. They lose that insight into their own difficulties. We sometimes see that they're starting to withdraw socially, starting to keep to themselves. We may see mood changes and irritability and things like that. At the moderate stage, I'd say people can't live by themselves anymore. They're not just disoriented to time, they're becoming disoriented to where they are. They may be having difficulty comprehending speech. They can't learn anything new anymore. So you put them in a new environment and they're totally lost. And example of that is I had a gentleman who came to me, and his wife only realized that there was something wrong with him when they went to Florida for a month. And he couldn't, after a month, he still couldn't find the bathroom in their condo where they were staying. But when he went back and asked, when I asked her, well, I was sort of asking, well, what did he do at home? You know, because he was quite advanced. He was in the moderate stages, and she was quite a bright woman. But when I actually questioned her as to what her husband did in his day-to-day life, you know, he's one of these gentlemen who had retired, and his life consisted of waking up in the morning, going to the kitchen table, eating the breakfast that his wife had prepared, walking to the living room, sitting in the lazy boy, walking back to the kitchen, sitting down for lunch. So he didn't do very much in life. So she didn't really notice that he had a problem till they went to a new environment. People can also start to have a lot of behavioral problems in this stage. They'll have delusions, and common delusions are, somebody's stealing my stuff. Because you put things away and then you can't remember where they were, but you don't have a memory problem, so somebody must be stealing it. They may have delusions that their spouse is cheating on them. Sometimes because the brain, as the disease progresses and affects more parts of the brain, it can affect the areas that interprets what's coming in through their eyes. So they may have trouble identifying objects, so they may have trouble identifying the people close to them, or they may, for example, not realize that a picture on the wall is not a human being. And so I've had patients whose families tell me, you know, well, she tries to feed the pictures of her grandchildren on the buffet. You know, they're unable, so these people may, in some cases, become aggressive. And often they'll, you know, one of the ways that we can precipitate somebody becoming agitated or aggressive is if we ask them to do things that are beyond their abilities. So it's very important to sort of look at what they're able to do and try and make things simple and at their level of comprehension. And that's where I think especially things like the Alzheimer's Society is very helpful in helping people to deal with these kind of problems. So at this stage, people are unable to shop, cook. They're usually unable to go out of the house by themselves because they're going to get lost. They may be restless, anxious, depressed, and they're starting to have problems with taking care of themselves with dressing and grooming. But as the disease progresses, and this is getting back to my analogy of an onion, we're getting, peeling off more and more layers. At the very late stages, people forget how to talk. Their verbal output as the disease advances may be limited to a few words. Their remote memory is starting to go, so they may, at very late stages, they no longer may recognize their family, it's very upsetting. They can't dress or bathe themselves anymore. They've lost bowel and bladder control. And they'll forget how to walk. And at the very end stages, people forget how to swallow. Not everybody dies of Alzheimer's disease or other forms of dementia. They often die of something else. So they die with dementia, not of dementia. But if you actually die of dementia, people will usually die either of dehydration or pneumonia because they can't swallow properly anymore. So every time you give them something to eat, it tends to go down into their lungs. And even to put in a tube to feed them is not an answer because all of us make actually probably this much saliva a day. So even if you put a tube directly into their stomach, the studies show that they still die of pneumonia. So at the very last stages, families, we do a lot of counseling with families as to what's actually going on, but we encourage them. What we do is we alter the consistency of the diet. We'll make the food like baby food, and there are products that you can add to liquids which will thicken them up to like a pudding consistency, so that makes it a little safer. And sometimes if people are very devoted, because it just takes so much time when somebody's forgetting how to swallow to get any food into them, but devoted families can keep it gives them something to do. It allows for some human contact at the very last stages, because at that stage, I think all you have left is touch. Touch. When Pamelia emailed me and told me that the theme for Alzheimer's Day this year was the faces of dementia, I wanted to somehow get this slide into my presentation. And this is a series of self-portraits, and I'm really sorry I don't remember the name of the artist, but the first one was done in 1967, and this is 1996, 97, 98, 2000. I think this is the last painting that he did in his travels through Alzheimer's disease. But I thought it's an interesting sort of portrayal of how the disease affects people's ability, just looking at somebody who was a very talented artist and how the disease slowly took away his ability to do what really was his life's work.
In part 2, Dr. Vaitekunas will discuss things we can do to prevent dementia, some treatment options, as well as the latest research findings.